Good afternoon, everyone, and thank you so much for joining today's event, Eliminating HIV/AIDS and Hepatitis Inequities Among African Immigrant Communities in the United States, a conversation with federal and local partners. This webinar kicks off our week-long celebration of National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, or Naira Day, which is observed annually on September 9th. My name is Beatrice Sovich, and I am a Public Health Program Coordinator at the Hepatitis B Foundation and the coordinator of the Coalition Against Hepatitis in People of African Origin, or CHIPO. We are excited to be joined today by a panel of very distinguished guests who will share with us their thoughts and ideas on current events, current efforts, as well as actions that are still needed at the federal, state, and local levels to ensure that African immigrants and refugees in the United States are represented in health data and policy decisions, and that elimination of HIV/AIDS and viral hepatitis in these communities can be achieved. Before we begin, just a quick note about the technology of today's event. As you can see, this event is being hosted in Zoom webinars and is being recorded for future viewing. All audience members will remain in listen-only mode throughout the course of the webinar and will not be able to turn on video. This event is also being broadcast on Facebook Live. We will be taking audience questions throughout the panel discussion. So should you have any questions, please feel free to type them into the Q&A box, and we will do our best to answer them all as they arise. Thank you very much again for your participation. So we will start by providing a brief overview of Naira Day and its history and context, and then we will introduce our esteemed moderator and guests before beginning with the panel discussion. So celebrated annually on September 9th, Naira Day was first created and observed by a group of activists in New York, Washington, D.C., and Boston in 2014 and has been celebrated on the local level ever since. And this day is aimed at bringing local and national attention to the health issues of HIV/AIDS and viral hepatitis in African immigrant and refugee communities in the United States in a way that is both culturally and linguistically appropriate. By addressing some of the unique issues that African immigrants in the US face in accessing HIV and viral hepatitis prevention, diagnosis, and treatment, such as stigma, limited access to healthcare services, language barriers, low acculturation, and social and economic marginalization, Naira Day uses awareness, education, and resources to empower communities to take charge of their own health and dismantle stigma. And it also provides a chance to encourage and advocate for policies and practices that promote healthy African immigrant communities, families, and individuals. With a rapid population rise in African immigrants in the US over the past several decades, it is critical to raise awareness among African immigrant and refugee communities and among healthcare and social service providers about the increased risk of viral hepatitis and HIV/AIDS in these communities, the potential consequences of these viruses, and opportunities for prevention, diagnosis, and treatment. So without further ado, we are very pleased to introduce our panel for this discussion today. Our guests this afternoon include Dr. Jessica Deeren, Viral Hepatitis Policy Advisor at the Office of Infectious Disease and HIV/AIDS Policy at the U.S. Department of Health and Human Services, Tolu Arowolo, Chief of the Center of Viral Hepatitis at the Infectious Disease Prevention and Health Services Bureau at the Maryland Department of Health, Omega Tawonesbi, Executive Director of Immigrant Community Services Incorporated and a member of the African Affairs Advisory Group in Montgomery County, Maryland, and Boatima Ntiri Reed, Director of the Hepatitis Team at NASTAD, or the National Alliance of State and Territorial AIDS Directors. Our moderator today will be Chioma Naji, who is the Senior Program Director of the Multicultural AIDS Coalition in Boston. So with that, I will hand it over to Chioma, and thank you so much.
Good afternoon, good morning, depending on where you are in the United States. Welcome, everybody. I'm very excited to be here today and have this conversation with some wonderful individuals who are doing some amazing work. So maybe what we can start with is you all just first, we have a short amount of time, we have a lot to cover, right? So we're just gonna jump right in. So if you all can start with sharing a little bit about your agency, briefly about what your agency does, and then let us know about what kind of work is your agency currently doing around immigrant health and particularly around health equity. So let's start with Jessica.
Hi, good afternoon. Thanks for inviting me for today's webinar. So I'm with the Office of Infectious Disease and HIV/AIDS Policy. Our office helps coordinate federal activities in viral hepatitis and HIV. We recently released the Viral Hepatitis National Strategic Plan and the HIV National Strategic Plan earlier this year. And so our next steps are in developing the implementation plans of those national strategic plans. So I'm sure many of you already know the national strategic plans are a whole of nation approach to trying to eliminate viral hepatitis by 2030 and end the HIV epidemic. So we included in those national strategic plans are priorities to address disparities. So we have indicators which will monitor progress on the national strategic plans, and those indicators also include disparity indicators. And we specifically focus for viral hepatitis on Asian American and African Americans, and that includes immigrants in that population. So we have a real focus as well on health equity within our office and in this administration. So part of our effort is trying to improve access to healthcare and addressing health disparities and addressing the barriers to healthcare, including stigma, discrimination, language, and cultural barriers. So I look forward to continuing this conversation. That's a quick overview of our office and the work that we do.
Thank you, and I'll switch it over to Botuma.
I can unmute myself. Hello, everyone. And good morning and good afternoon to everyone. Just want to say a huge thank you to all the folks who have taken a tremendous amount of time to coordinate today for us to be able to have this conversation. So as Beatrice shared, I am the Director of Hepatitis at NASTAD. And at NASTAD, we focus on providing technical assistance and capacity building to health departments. But we also work in close coordination with community and our organizational and community partners. Our vision, as we're just moving into a new strategic plan, is a world committed to ending HIV/AIDS, viral hepatitis, and intersecting epidemics. And our mission is to advance the health and dignity of people living with and impacted by HIV/AIDS, viral hepatitis, and intersecting epidemics by strengthening governmental public health and leveraging community partnerships. Now, of course, we all know that a mission and a vision are really designed to be your North Star, to always be your guiding light, to be the place that you look. But one of the most critical priorities that we have identified at NASTAD as we're moving forward as an organization is doing so with health equity at our forefront and anti-racism as a framework that we move within. And so that can be a hard place for health departments, right? We are working with governmental institutions and race and racism has been heavily politicized. It in and of itself, in a lot of ways, is a political feature. And so we are constantly working with our health departments and with our community partners to ensure that recognizing what some of these things, what the concept of health equity can be transitioned into, that we focus on what it is. And what it is an understanding that not everybody accesses health and healthcare in the same way, that structural barriers, historical prejudice, historical racism are all features that impact one's ability to be able to access these systems. And so we are really driving our work with that understanding at the forefront at all times in our efforts to really strengthen access to HIV and viral hepatitis prevention, care, and treatment so that we can end the HIV epidemic and eliminate viral hepatitis.
That is a big task, and I look forward to hearing how some of the ways in which you're partnering with specifically African immigrant communities to do that work. So I'll switch it over to Tolu. Please tell us a little bit about your agency and some of the work you're doing around health equity and immigrants.
Awesome. Thank you. Thank you for inviting me, and good afternoon, good morning, everyone, from wherever you're joining us from. I work at the Center for Viral Hepatitis at the Maryland Department of Health. And at my center, we coordinate the state response to viral hepatitis interventions, which includes prevention activities, including prevention education, promoting vaccination for hepatitis A and B, promoting rapid screening for hepatitis C, and also linking these patients who are positive to care. And also we advocate for treatment for all clients who get positive with hepatitis C. So at the Maryland Department of Health, really, we run an inclusive program. What I mean by inclusive is the fact that Maryland Department of Health, as their mission, claims that every Marylander, if you live in Maryland, you should get access to quality healthcare, including prevention activities. So irrespective of immigration status, you are ensured to have quality prevention education, intervention, treatment for viral hepatitis, for HIV, for STI, and also for chronic and non-communicable diseases. And also at the forefront of our work, we make sure that our health metrics address and monitor inequities where they exist. So regularly, we go through our surveillance data to analyze it and then see gaps in terms of population groups where they are not getting key access to interventions. Recently, at my office, at my center, we recently conducted the first viral hepatitis epidemiological profile. This is a document that actually looks at the distribution of viral hepatitis A, hepatitis B, and hepatitis C across Maryland. This is the first time we're doing that. And we're able to document that Asian immigrants and African immigrants have the highest prevalence of hepatitis B. And they are actually distributed in 3 key jurisdictions within Maryland. So we're using that data to begin to put together interventions that we address that these special groups get access to prevention education, screening, linkage to care and treatment, among other things that we're doing in form of collaboration with the Office of Minority Health, collaboration with the Center for Immigrant Health, and other agencies that look around immigrant health.
Great. I mean, it's, you all definitely have started the path of identifying what's going on, right? Using data and measurements to really find out what's happening at the local level. Omega, please let us know about your organization and a little bit about how you all are thinking about health equity, particularly around African immigrants, because your organization's focuses on African immigrants.
Omega, you're muted. Okay.
Oh, there we go. Sorry. Good afternoon, everyone, and thank you for convening this important discussion. So as the moderator mentioned, I work with Immigrant Community Services as the executive director, and this is a nonprofit organization that serves in the DC metro region, and we serve primarily immigrants, minorities, and refugee population. And at the same time, I also work with the African Affairs Advisory Group in Montgomery County. And this is a group that advises the county executive and the executive leadership in the county on issues that pertain to Africans that live and work in the county. So I'm gonna have 2 hats here. I'll speak sometimes from the African Affairs Advisory Group perspective, and then from the work that we are doing on the program with Immigrant Community Services. So as far as health equities is concerned, with Immigrant Community Services, our purpose is to ensure that all immigrants or minorities or refugee populations that are in our jurisdiction have access to health, equal access to health, to quality healthcare. So we do have in our program offerings a community health program that addresses mental health issues, because we find that most of our constituency are immigrants or refugees. They have run from someplace and have resettled here, they have a lot of mental needs that need to be addressed. And we also, of course, have an HIV program that helps our clients to stay within care. We identify people who have been diagnosed, who have fallen out of care for whatever reason, and we try to mitigate the reasons why they've fallen out of care so we can get them back into care. And that is what we focus on as a way to get health equity, to make sure that our immigrants and minority populations are getting the care that they need. And then from the advisory group perspective, we as a group advocate within the county to improve the outcomes for all the immigrants that live in the community, be they health outcomes, economic outcomes, all kinds of socioeconomic outcomes. So we have a healthcare program, a health working committee in the advisory group that focuses on health issues. And I can speak more about that as we go on.
Great, thank you. And so, you talked a lot about, everyone talked about sort of the initiatives, health equity initiatives that are in place. I would like to hear a little bit about what are you finding are some of the challenges around implementing those health equity initiatives, and specifically, what are some of those challenges around making sure that there is a clear focus around immigrants and refugees? And it's open to anybody to start.
For us in Montgomery County, the DMV area, the DC, Maryland, Virginia area is home to a lot of immigrants. I think it's probably the fourth largest in the entire country. So we have immigrants that come from various parts of the world. And we started our organization, Immigrant Community Services, because we felt that even though there were a lot of services that help people in general, we needed culturally specific services that focused on the population in question. So we developed this program to address the education piece, because immigrants come, they are unfamiliar with the community, they don't know what is available for them, and 9 times out of 10 they get sent to the social services department, which is great, but there is a lack of cultural understanding of some of the nuances that affect these immigrants that hinder them from getting the information or from accessing the services. So we try to bridge that gap by providing navigators who are from the same community, who understand the culture, who sometimes speak the same language, physicians, providers who are also from that same community. And this is our way of trying to ease the burden of having to find information, and then you go to a totally different person or provider who's different from your culture, who doesn't really understand the nuances. So that's our approach, and that's the gap we identified, and that's what resulted in us initiating this program.
Anybody else would like to?
I'll chime in. I think at the federal level, one of the challenges is really aligning our activities and funding in this area to try to achieve the goals of our strategic plan. As Omega just commented, there is a lot of services that immigrant populations require, not only dealing with moving to a new country, but navigating our healthcare system, which is complex. And then within that, to try to share the message that we need to also screen for viral hepatitis and HIV. So sharing that message with our providers and also with our community to increase awareness of that issue.
Just quickly, I would like to re-echo that, because we see that at the local levels, where the lack of integrated programs are not really happening. Most of the time, I see that providers or non-community organizations who have the funding to promote HIV interventions just want to do that and take their books that we've done it. So when you introduce new programs to like viral hepatitis, you can do rapid testing, you can give the same clients syphilis testing, hepatitis testing, and HIV testing just in one setting. They are not really quick to adapt to that. They just still want to go ahead with just the intervention that they are comfortable with. So I think this is something, of course, that we can address.
Absolutely, I agree, Tolu, because we do find in the course of our work, as we work with immigrants, we target mostly, at least for African immigrants, we know the biggest entry point is churches, faith-based organizations. So we target a lot of ethnic churches where we do go and have testing days, and we try to include all the kind of tests, not just HIV, which we do, but other STIs as well. But I do agree that folks tend to be siloed in the area in which they provide and are not providing holistic care or holistic services, which make it easier for the people receiving the care if you provide everything in one setting and there's not multiple going here, going there, which is often difficult for new immigrants who are trying to get settled. So I definitely agree.
Yeah, I mean, thank you for bringing up all these challenges, because I think it's important to highlight challenges, not just on the local level, right? Like, what does it mean to provide those direct care services, but also for individuals who are really working within sort of government or local or state or federal government. There are challenges to even getting this work done, right? And so totally you brought up sort of the need for integration of services and also sort of data, right? We need the data in order to be able to really say that there is an issue and start really talking about allocation of funding and services. And this is one of the reasons why Naira was created, right? It was created in 2014 for this purpose, and to sort of make sure that we are keeping in the forefront some of the needs of African immigrants in particular. So I would like for you all to share a little bit about how you think Naira Day can impact your work. And particularly you can share, I know I'm gonna put both of them on the spot because I know NASDAQ has in the past been involved in some Naira activities. So ways in which you have engaged with Naira and how that has benefited some of the work that you're doing in addressing inequities.
Yes, thank you. Happy to be put on the spot, especially on that one in particular, and have some thoughts about challenges too, but I'm going to try to keep myself from going on a tangent. So I'm excited. I definitely have to say many thanks to Chioma and a number of the folks who are on the line and participating today, because at NASA, we have been thinking about how we can more thoughtfully approach immigrant health in the context of our work on HIV and viral hepatitis. And so last year was a big turning point for us when we worked with CHIPO, with Hepatitis B Foundation, to develop a blog post that was designed for health departments to really start thinking about opportunities to engage with African immigrant and refugee communities, and to do so recognizing something really critical. And so though we didn't say this direct point in the blog, a part of it is that there's so much diversity. So when we say African immigrants and refugee communities, we are talking about a continent of folks who speak thousands of different languages, who are of significantly different backgrounds, and who in and of themselves within their own communities are trying to identify ways of connecting and working through some of the issues and challenges that we've talked about. I raise that because we also are in a nation that, if we really want to go there, we don't learn about Africa. When we learn about Africa, much of it is about the stories and the background and experiences of Africans who arrived in the Americas. But when it comes to actually fully understanding the continent, its people, its culture, it's not something that we're heavily engrossed in this nation. So not only when we go into Naira Day and into other activities where we're focused on African communities, are we saying that we need to think about it in the context of the work we do? So in this case, HIV and viral hepatitis, we're also saying that this is a major moment for us. And so typically what happens when you are in a position to work with, never on behalf of, but working with a community that you have not necessarily been engaged with in the past, it can feel intimidating. And sometimes when we're intimidated, we don't do. And so a part of what we wanted to make sure that we were doing too is to say to our health department colleagues, it's time to get to know your African communities in your jurisdiction. And if you're not quite sure how to take that first step, let's talk about how to do that. And so a lot of the conversation was around, did you know that there are a number of organizations that are already within your jurisdiction who are doing the work, such as Omega's organization, of ensuring that African communities are accessing healthcare, that they're accessing quality care, that they're working with providers that have traditionally worked within these communities and or who are from these communities in order to ensure that access is happening, particularly when it comes to prevention like vaccination and regular care, but also when it comes to specialized care such as for hepatitis and for HIV. And so we're encouraging that ongoing conversation by participating in Naira Day activities, but also recognizing that this is a single day. And it's a day to remind us, but that we also want to know that consistently we are doing the work, and that if you are nervous or unsure of how to do that, we have the partners, we have the technical assistance and supports there to help you do it. And we have leaders at health departments like Tolu who are doing the work and can really be an example for other health departments of how to do it.
Great. Yeah. Get to know your community. I think that's definitely a take home message. You know, not only in terms of what countries are represented, but also what are the networks in communities, right? Because we know that our immigrant communities, our African communities are coming with assets and networks, right? We're not talking about communities that have nothing, right? And so as you're getting to know what countries are there, you're also getting to know what are some of the key leaders, what are some of the key organizations like Omega's organization. So I want to sort of expand sort of this question around what are the ways in which some of your agencies are directly partnering with or building alliances with African organizations or African leaders and communities?
Really, Botima, you rightly summarized the last question. And actually, our departments are already beginning to do that. I know we are planning right now, but we're already taking a step ahead to begin to implement that. And at the Maryland Department of Health, just before COVID-19, we started putting together plans to do this. And in fact, during the epidemic, we eventually sealed a collaboration with a local provider in Prince George's County, who actually the practice target a lot of African immigrants and refugees. So when you say get to know your community is very, very important. This organization, all through the epidemics, providing rapid hepatitis C screening, was providing hepatitis B screening and also providing vaccination, which keep our activity going on all through up till now. So it made me to realize really that our department, even that the local department that they have a clinic, they can't do it all. They can reach out with local providers within their community and provide them with maybe test kits, do capacity building for them, do a lot of awareness about services that are free and collaborate with them. And in return, get their data so that we can be able to analyze what goes on at the end of the day. So this is something we're already doing. I know you are planning to put this forward for us, but it's already going on. And I believe a lot of health departments can do this because we all the time cannot provide direct services, but we can collaborate with key leaders, key providers within that community who can do this. And that is something we're already doing at the Maryland Department of Health.
So, and I think it's important for you maybe to give a little bit more context, because I think this is a very interesting strategy to use. One, folks might not know that Prince George County is one of the biggest represented counties of African immigrants, and it also has high rates of HIV and hepatitis. And so that strategy that you mentioned, can you talk a little bit about the provider? Because the provider is not sitting in a community health center. When you say provider, what do you mean?
Yeah. So the collaboration actors started in the form of, we have a grantee, Hepatitis B Initiative. They do a lot of great work around providing the hepatitis intervention, viral hepatitis intervention and HIV to African immigrant community, Asian immigrant communities, and also refugees in Prince George's County, in Montgomery, and even across Maryland, essentially. So HBIDC, as they are called, Hepatitis B Initiative DC, also subcontract with this local provider. And I think this relationship must have been from the fact that they identified this clinic, and the name of the clinic is SDM1 Stop. I don't know what the full meaning is, but it's SDM1 Stop. One doctor, I'm sorry, I forgot the name, but she's really a great nursing practitioner practicing in Prince George's County that manages this clinic. And they actually provide viral hepatitis intervention, HIV, STI, hypertension, diabetic services, all inclusive to this community in Prince George's County. And as Riley said, Prince George's County is actually home to a large number of immigrants, especially African immigrants in Maryland. And so this community, these local providers, we actually invited her over to join one of our programs. In Maryland, we have this program we call Maryland Communities-Based Program to Test and Cure Hep C. So I have both in my head that actually started this program. So I inherited it from her. So that program, actually, what we do is to collaborate with Johns Hopkins University to recruit and train primary care providers on how to evaluate, diagnose, and treat hepatitis C. And it's been largely successful because right now in Maryland, you don't need to refer an hepatitis C client to a GI specialist or an infectious disease specialist to treat. Right there in the community, primary care providers can provide this treatment. So that's what we did with Dr. Ndechua. Yes, that's her name. So we trained her and she went back to Prince George's County, just doing like in a month, they can do up to about 300 tests of rapid testing for hepatitis C. And right there, if they pick any positive client, she's ready to treat without needing to refer to a specialist. And this is really a beautiful program. And we're beginning to tell other jurisdictions to know your community, know a provider who is interested in collaborating with us. We train you and you'll be able to provide this wonderful service.
Excellent, because it's a provider who already has the trust of the community. And so the only thing that's needed is that capacity building and the tools needed to administer the test. So thank you for sharing that strategy. I'm sure a lot of people sort of are thinking about how that can be used in their own jurisdictions. I wanted to switch a little bit and talk about more specific to some of the issues that African immigrants deal with. We know that stigma is a barrier in HIV and hepatitis. Is a barrier for prevention, treatment, and care, right? People accessing these services. And for African immigrants, and in general, Black immigrants, that stigma is heightened because of other intersecting oppressions, right? And so those oppressions are based on race, so racism. And then we know that, the oppression of xenophobia, nativism, because someone is an immigrant, and the ways in which those can be compounded by gender or sexual identity, right? So it'd be great to hear if you all have any thoughts first around ways in which systems or agencies can really start understanding that, right? These intersecting oppressions, because they're not awfully talked about, right? And sometimes we talk about stigma as a way to mask what we really need to be talking about, which is racism and an intersection of racism and xenophobia and all these other oppressions, right? So are there ways in which, you know, your organization is dealing with it, or even thoughts on how we as a collective field can really start dealing with it? And Jessica, I'm going to ask you to speak a little bit about the strategic plan, the viral hepatitis strategic plan, and if there's any work happening in the strategic plan around stigma and other intersecting oppressions, and then others can sort of take on from there.
Yeah, and I also wanted to congratulate Tolu and the work that you are doing in Maryland. That sounds like a great best practice to share. And also echo that we also support the syndemic approach in the National Strategic Plan. So a whole of person approach addressing HIV, viral hepatitis, and STI, and as well as all of these other social determinants of health and other factors, such as discrimination and stigma that can contribute to perpetuating viral hepatitis and HIV epidemics. So in the viral hepatitis National Strategic Plan, yes, we have many objectives and strategies that focus on addressing stigma and discrimination, increasing culturally appropriate and linguistically appropriate services in our healthcare providers, and increasing training and capacity, and the focus on collaborations. So as Tolu was discussing, that's a really strong component of the strategic plan. We can't do this on our own. Often viral hepatitis and HIV funding streams are siloed. So the strategic plan also calls out trying to align our funding streams. And our next step is a syndemic focused steering committee. So our federal partners that work in HIV, viral hepatitis, and STI, we are convening in a syndemic steering committee to address all of the issues that our communities face across these three disease areas. And included in that is addressing the social determinants of health. And in the HIV plan, so as many of you may know, the HIV plan is another version of it is coming out. And in this version, there's going to be a really strong focus on health equity, and they are bringing in other federal partners that weren't as strongly represented the first time around, including the Department of Labor, Department of Housing and Urban Development, so that we can continue to strengthen our partnerships with other areas.
Yeah, that's amazing, because I definitely sort of work force development for African immigrants and other immigrants who typically come into the country with degrees and have a challenge with being able to work in their field. And so really thinking about that intersection with labor, I think is going to be very interesting. So I'm excited to hear that. Thank you for sharing that, Jessica. Are there any other thoughts around sort of around stigma and other intersecting oppressions and ways in which we can start thinking about addressing, or ways that your agency is talking about addressing?
So in Maryland, really, like I mentioned earlier, it is an inclusive program that we really run. Mm. I've listened to other folks from other jurisdictions where they talk about racism and they talk about the issue of stigma. Mm. I really think that I don't really see that a lot in our programs in Maryland. But that said, we are beginning to have conversations around workforce development, where at the local levels, you can look at the components of the providers, like maybe you have 5 nurses, 3 case managers, one doctor. Are all of you white? Do you have at least one person in this team that is Black or an African immigrant? So that when an African immigrant walks in or a refugee walks in, they can see someone who looks like them. And that can instantly make them feel comfortable when they walk into that clinic or they walk into that health department. So that conversation is already going on. And I'm beginning to think HR is taking that into consideration. But really in Maryland, we run an equal opportunity employment system where really either you're an African immigrant, you're Asian immigrant, you're anybody, you have equal opportunity to be employed. So that is beginning to take shape. We are really in the local departments, wherever health is going on, healthcare is going on, you can have a full component of ethnic groups, race, or gender that is balanced to be able to be sure that when anybody walks in, they can be comfortable to get care in that setting.
I think one of the things that your comment brings up for me is what are the ways in which we're ensuring that our principles and values show up in practice and in policy, right? Because often we know that there could be a gap, right? And so the ways in which we determine that our services should be implemented, or the ways in which we think about diversity and inclusion doesn't necessarily happen on the ground, right? Doesn't usually happen, doesn't necessarily mean it happens on the ground, but I think you gave a great example in terms of how medical teams need to be just as diverse as the community that they're serving, and be a representative of the community. Omega, I think you wanted to say something.
Yes, I wanted to say that on the issue of stigma, because this is a big issue that we face as we do our HIV outreach, because we are conducting outreach to folks who are have fallen out of care or have never started care to begin with, even though they have a diagnosis of either. We deal mostly with HIV. So the issue that we face is that the stigma might not necessarily come from care from the providers or any, like what Tolu is alluding to, that there is diversity in the providers. Yes, there definitely is diversity. However, the stigma comes from within the recipient. So I feel some type of way about my condition, so I am concerned about going to the clinic, especially if there's an African there that I know who might be connected with my community. Word might spread out that, I mean, this is in someone's mind, that word might spread out, even though we know of HIPAA and everything, but it's some cultural thing that is in us that pulls us back. Because we do find that patients who, when we speak with them and say, okay, so what has happened? Why are you no longer coming? And they're like, oh, well, the other day I came and I saw such and such at the clinic and I didn't want them to see me. Okay, they have nothing to do with what you are here for. They don't know why you are here. So overcoming those challenges that are in the mind, it's kind of like decolonizing our mind or breaking it down in the mind. That's where the stigma still lies in terms of our constituents, the patients that we serve.
I think oh, go ahead.
If I can say something really quickly too, I think something significant to consider, and I want to give a shout out to Isabel Lechuga from our team, who took on this topic recently of centering immigrant lives within the Black Lives Matter movement, and where do immigrants exist within that. And it's a really important question, because when we talk about all these critical conversations that have come up as a result of the Black Lives Matter movement and actions, when African immigrants are presenting, they present as Black. That's the first thing, no matter what one wants to say or kind of move around, the first thing that a provider, a community member, whoever it may be, they present first as Black. And so without question, all the isms that we're talking about that affect Black people in America, African immigrants are very much a part of that. So just thinking about the intersection for everyone to just always have that at the forefront of their minds.
Excellent point. Thank you very much. And what, something, Omega, that you were saying, I think was sort of in a response, indirectly responding to a question that came up from one of the audience members who offered that their organization is dealing with stigma as it relates to African immigrants. And it's internalized stigma, because I think that's what you're referencing, Omega, the way in which we internalize stigma. And so, the reality is there's fear around accessing services because, there's a lack of trust in the government. And even though this organization has patient navigators who speak their own language, they're having challenges with their clients calling back, right? And coming back for services. And I think one of the things you brought up is this internalized stigma, and really thinking about how the program and the organization is laid out, so people will feel comfortable going to an agency that might have individuals from the community working, right? It's sort of this catch-22 that happens. My program is we have our frontline staff are individuals from the community. And so what we've definitely focused on doing to address that stigma or that fear, that confidentiality, is the trust. I mean, you cannot overlook trust. Right. You cannot overlook the time and commitment needed to build these relationships with communities. So when they see you in the community and I'm testing somebody for HIV, right, and they'll see me on Sunday at church, or they'll see me the next week at a baby shower, they know that I will not be talking about their HIV status or the results of their tests. Right. But Omega, I don't know if you have some insight on ways to sort of address sometimes that challenge where you might have individuals working your front lines who are from the community, and maybe the community still sees that as that's still a barrier for people to come in. I don't know if there's work you've done around that.
Yes, so we do see that in terms of testing. So whenever we have a testing event, because we, like I mentioned, we do target houses of worship, religious worship houses in the area, and we do go. So obviously you are bound to run into somebody that you know, and so folks sign up and they want to know who's coming to conduct the testing, so they have that information ahead of time, and then they can be like, oh, okay, I'll show up. If they see somebody whose name is not from their community, they'll come. Or if they know that they are negative, they just want to come and say, okay, I'll show up then. It doesn't matter who's testing. But we do address that in terms of through our educational piece, because we have a roundtable where we discuss these general health issues plus these confidentiality issues. And in Montgomery County and Prince George's County, we have an HIV collaborative. And this is something that I wanted to mention earlier for the hepatitis, that all the players, most of the players in the HIV space are part of this collaborative. We meet every so often, we discuss issues, we discuss best practices, and we organize things that help on getting word out. Like, for example, we currently have an outreach campaign to encourage testing and to encourage people to know their status. And this is with the county. So these are community partners working with the health departments in both counties to get this this campaign out. So just a general robust educational campaign on demystifying all these things helps. And it makes immigrants or people who are new to this community know that, okay, if we say XYZ is B, then it means XYZ is B. There is no other shade in between. So if I say your information is safe, it is safe. Don't worry about it. You just take care of yourself.
Great points, great points. So I want to try to get in two questions before we close. The time went fast. Okay. So the first question, both of them are raised from the audience. The first question is, does anybody know of any resources that provide a list of African organizations in particular areas? The person asks, particularly around in the Midwest. I can offer a response, but I just want to see if anybody else has any resources. This is a fairly new community, right? really work around African immigrant health has started maybe 5 to 7 years. And so, but there are organizations in local communities that have been doing work with African immigrants for 20 plus years, right? And so it's really about finding those organizations that won't have health in their name, right? Might be specific to a country, right? Like the Nigerian Association, the Ghana Association, or faith-based organizations. Someone wrote in the chat. One resource that you can look at is the CHIPO list. And hopefully Beatrice will be able to put that link in the chat box. That is a beginning start to start looking and see if there are any of those organizations in your area. But I think that you have put forth a challenge for us to really think about how can we organize and support African organizations on the local level to come into this work and maybe think about how to create a place where folks can be able to convene. So I don't. Anybody else want to expand on that or have anything to offer? Okay, so our final question is around data. Somebody asked, what are the ways in which we can really start capturing this population in our local, state, and national data sets? So for some of the states that are collecting that information, Tolu, maybe you can talk about how you're capturing that information. Botima, maybe you have a more national lens on some ways in which, or strategies in which that's happening.
I can start. So really, it's very important that we have records and data showing what services are going on, or even beyond services, what are the burden of diseases, HIV disease and viral hepatitis, even at our jurisdiction. So in Maryland and across most of the health departments, we use the national database, where providers and clinics are mandated to report hepatitis cases and HIV cases. And these are done routinely. So at the health department level at my center, we collaborate with epidemiologists and surveillance officers who actually regularly look into the database, analyze the data, and look at the distribution to actually pick out where, in terms of geographical distribution, do we have these diseases highly prevalent. And that is one thing we have done in Maryland. My center put together the first viral hepatitis epidemiological profile for Maryland, and we're able to use the key findings from this analysis to begin to plan our viral hepatitis elimination plan right now. And in it, we're able to know that priority populations for us to target will be persons who inject drugs, will be to look out for the interests of people who have some history of criminal background, or they have gone to prison, or they're out of prison. We also begin to see that we need to look out for the interests of African immigrants and Asian immigrants when it comes to hepatitis B, and also to look out for the interest of suburban rural Maryland when it comes to hepatitis C. But without data, we are not able to see where we need to go with our various interventions. Also, this surveillance data is also enabling us to also be able to see the kind of providers we need to target, train them, and of course, give them some awareness about free services that are available for viral hepatitis intervention, services that are available for HIV intervention, for STI, and for substance use disorders management. So this we're doing because we have data, and we actually go into our database to analyze it and then use it to inform and also to redesign our intervention as applicable. So that is what we're doing in Maryland.
Excellent. Biltema?
Yeah, so I'll just say, one, I just want to say a huge thank you to Tolu for outlining and highlighting the work that happened with their epidemiological profile, because we are seeing more and more jurisdictions developing their profiles. We're also seeing more jurisdictions reaching out saying, how do I more effectively incorporate health equity and health equity considerations into our epidemiological profile? And so the opportunity to talk specifically about integrating African immigrants and refugees into those efforts, I think, is really significant and a great thing to highlight. Also to Jessica for highlighting the fact that within the national plan, it actually provides strategies on how to make sure we are considering and including immigrant and refugee health, including African immigrants and refugees in our efforts to eliminate viral hepatitis, and recognizing that you have key points within the national plan that you can pull from in order to inform those efforts. The last thing I'll just say really quickly that's exciting and relevant to this conversation is that in May 1st of 2021, CDC's Division of Viral Hepatitis put forth this significant cooperative agreement that went out to 59 jurisdictions. And we now have gone from only 14 jurisdictions in the nation that were funded for hepatitis surveillance, which might not sound like a big deal, but it's huge. This is our movement towards core surveillance. So we went from 14 jurisdictions funded to now 59 jurisdictions. So some of these conversations around how we can improve data and data collection were so hard to have with jurisdictions that had so little money to do so. I'm not saying they're getting, millions now. That has not happened just yet. But they do have more resources to inform their surveillance programs and to be able to look more into the demographics of the individuals behind the cases that they receive and within their surveillance system. So I think that will be a major movement in terms of having more data to inform our work with all communities, including immigrant and African immigrant communities.
Thank you. So we are at time. What I can definitely promise to everyone who has been on this call, on this webinar, is that we will send out these resources that we're rattling off, right? So you will get it in an email, a follow-up email, and you will get the recording. I am very, very thankful for you all. It's been an amazing conversation. I've learned a lot, and I definitely hope that this is definitely a start to continue to support and uplift Naira Day for the very reasons in which you all have brought forth. So thank you. And I want to hand it over to Beatrice, who will close by letting folks know about what we're doing for 2021 Naira Day. Thank you. Beatrice, we can't hear you.
Are you able to hear me?
Yes.
Okay, great. Sorry about that. So I was just saying thank you so much to our excellent panel and the wonderful discussion today. And it's really inspiring to know that we have such great leadership in the efforts to eliminate hepatitis and HIV in African immigrant and refugee communities. And thank you all so much for your participation today. And I know we're at time, but just to hold you for just a couple minutes before we wrap up, I just wanted to take a moment to share that over the course of the next week, we're going to be launching a social media toolkit that will include different actions that you can take that can help elevate the message of Naira Day and to help engage in advocacy and awareness components that are so integral to the day. And these range from everything from increasing involvement with African community-based organizations in your area to contacting your local elected officials to provide education about the day and the needs of African immigrant and refugee communities. So we'll have one action a day that is posted starting today and will run through next Thursday, September 9th, which is Naira Day itself. So you can follow any of the organizations that are listed on the slide on Twitter, Instagram, or Facebook. And we'll also include these in the follow-up email. And yes, thank you so much to everyone for joining us today. We really hope you found this session to be fruitful and engaging. I certainly learned a lot and that you can come away with greater insight. And we also listed the websites of each of the sponsoring organizations, which we'll also list in the follow-up email. And again, as Chioma said, we'll include the recording for this webinar, contact information for speakers, and all the resources that we mentioned. So thank you so much again to everyone for participating. And hope you have a great afternoon.
Take care, everyone. Have a great rest of the day and week. Be safe this weekend.